right, thanks for joining us tonight on PerfWeb. If you've registered for the program, this is worth 2.5 CEUs, Category 1. If you have not registered, you're not totally out of luck. You can still get Category 3 CEUs, and so that's worth something anyway. So tonight's presentation is going to be all about perfusion charting and specifically more about electronic charting. And as you know, I am your your host, Joe Basha. All right, so my other two guests tonight are Rodell Ibis is here, and you've seen him before on the show, and also we have Nate Badair, and Nate is, it's his first time joining us, but he's also working for HET here in the area. I need to mention a couple of very important things about our show. The first thing, the most important thing is that if you want to be a part of this community, the best thing to do is to subscribe. And you do that on the YouTube channel. Subscribing helps us in a lot of different ways. I just learned the other day that because of the number of subscribers that we have, we were able to see our stream going out to you immediately. Well, it's about 2 seconds delayed, whereas before it was 20 seconds. And if you're doing a show like this, it helps a lot because we get to see what we're getting out to you right away. We can correct errors immediately. So please subscribe. That helps quite a bit. There is a button somewhere on the screen here. I think you can see it, but you can hit the subscribe button, and that's how you do that. The other thing is to remember is to please download our flyer and pass it out to friends. Send it to friends. That helps us a lot as well. And you can also like us on Facebook, which helps us in other ways. We're also streaming on Facebook as well as YouTube. It's really important. We would really like to have people call in tonight. We're going to have the call-in number on the screen the whole time. And unlike other shows, you can call in anytime. We may ask you to just hold off for just a minute with your question if somebody is presenting, but calling in is very important. It helps the show. It helps us kind of direct what we're going to talk about. Okay, so at this point, I had something very important to get off of my chest. I thought that I should do this live on the internet, and the fact is, I'm not Joe Basha. I have to tell everybody this. You guys may have thought I was, but I'm actually Patrick O'Toole, and Joe asked me to host the show tonight, which I'm happy to do. So our first presenter is going to be Rodell Ibis. He's got a presentation that's very appropriately named Electronic Medical Charting for the Perfusionists. And call in any time. The number is right down on the screen here. We'd love to hear from you, and we'll direct our conversation based on your call-in. Rodell?
Oh, all right. Well, thank you, Patrick. Actually, AKA Joe. You know, it's kind of funny that you actually had that. It quite surprised me. I actually had to take a double take. You're not.
I put that on moments before the cameras went live.
Yeah, you put it on moments. Hey, so that's quite interesting. Where am I on camera here? Where am I looking? Okay, great. So we're talking about electronic medical records for the perfusionist. You know, it's something that isn't the sexiest topic. You know, when Joe asked, Patrick and myself about what we're going to talk about, like something that's, relevant, and I just dropped electronic medical records, and I didn't think it would stick. I'll be honest with you. But it did stick, so, that now that I delved into it, it was something that, I looked at, maybe 10 years ago in my career, and I had a passion for it. But now that new technologies have come out, I've gone down the rabbit hole. So here we go.
A lot of choices.
A lot of choices. So why should I convert? It's like you see here, like actually I have an homage to one of my favorite instructors from here at Texas Heart, to the left there, and he is with a student, and he always yelled at me for charting. And I'll be honest, I will never forget that. He said, always take care of the patient first. It was actually one of my first cases, and if anybody knows me, I am very, very OCD. I like to chart everything. I always like to paint that picture. So, and there you go, and you have another perfusionist there all by himself, and he's charting, and and he's doing his thing.
Could you address something?
Yes.
Okay, so when I was a new perfusionist, I was taught to use the chart to make sure that you understand and remember the scan, everything that you're trying to look for.
Absolutely.
And I do worry sometimes about, when electronic charting comes, younger people who are just starting off in perfusion not getting that scan down the way they should.
Right.
What do you think about that?
So that is actually a good question. Like, is it something that like we add or subtract in the scan? If it's something, we're going to talk about these advancements. Like, I don't know, does it need to be in the scan? Like, I look down and I'm writing something, and it's, I think to myself sometimes, is this a handwriting class or,
Yeah.
we're not even taught cursive in grade school anymore. So it would just be funny. It'd be funny looking. So it's not a handwriting class to me. So I know, how do you feel about like adding that or subtracting that in the scan?
For me, I'm with Patrick a little bit. It helps as a reminder that, hey, it's time. But if you're waiting 15 minutes to do your scan, you're messed up anyway.
Right.
So from that standpoint, then the electronic charting actually helps a lot because your mind can be on what you're doing. You can constantly be looking, should I make changes? It especially applies if you have an inline gas monitor, things like that.
Right. But yeah, let me get back to that question. So that is actually a good question, with the scan. But, so I posed the question to you. What if you were in a dire emergency and you're not able to get to your chart and something catastrophic has happened?
Yeah.
So, but, we'll explain that, throughout.
Well,
throughout
let me pose this question
Yes.
then. Have you ever, either of you ever, been charting and then looked down and see your reservoir drained?
Close.
Close,
Close,
right?
but
So
never
the
stop-
chart was
never
a
total.
distraction.
Yes.
Yes, absolutely. And that's why
You do enough cases, that
sensor.
will happen.
Yeah.
That's why we have like safety devices.
Yeah.
So yeah, it's come close. I mean, not to say I don't know how to fix it, but it can happen. It's like, as one of my instructors said, like, if you haven't pumped air, you're about, how
about
did it go?
to.
You're about to. You're not. No, it's like you
There
haven't
those-
done it long enough.
There's those who have and those who have not yet.
Yeah, that's correct.
Or will. Or those who
Yes. So, like, we're talking about modern technology. I mean, if you look at here, I just have this slide of a flip phone. I mean, guys on this panel have had a flip phone, and we gradually made it to the text messages, or excuse me, the text phones. Where you had to click on like multiple numbers and you got your letter. Now we have phones that are smart. Like, I can pick up this phone, open up an app, get a pizza, and at the same
pizza.
time, get a car ride to get that pizza.
While on pump.
What? Yes, yes, while on pump. I don't recommend it, but it
can
can
do it.
happen. It can happen. And the same thing with computers. I mean, everybody on this panel knows that, hey, I had this desktop computer, and you still see desktop computers in the OR. I mean, but now we're starting to see tablets.
Yeah.
We're starting to see tablets. We're starting to see, not just from our end, but, anesthesia. So that's, they walk around with that, and that's a nice piece of technology. They don't have that chart anymore. So where are we at?
Oh, they're
Why-
way beyond us. in
I mean,
charting,
they're
absolutely.
way
Yeah.
beyond us. I mean, all the disciplines, I feel, that are way beyond us in the realm of technology. So where are we at? Sorry, I'm just getting used to this. So let's see where this all first started. It actually first started, the ball got rolling with former President Obama and the Affordable Health Care Act, Obamacare. So what he mandated was electronic medical records for meaningful use. And what does that actually mean, meaningful use? It was like really, in order to maintain like existing Medicare and Medicaid reimbursement levels. And so let me give you this slide about what meaningful use is, which was kind of interesting. What's meaningful use of electronic medical records or health records, as defined by health healthit.gov, not health it, health IT. So,
they're
information
going to
technology.
define what meaningful
So
use
yeah,
is.
yeah. So that was a kind of interesting what meaningful use is. I mean, I have a general idea, but they have the idea. It consists of using digital medical and health records to achieve the following. Let's see. Let's move that. The following. Improve quality, safety, efficiency, and reduce health disparities. Engage patients and family. Improve care coordination, population, and public health. And maintain privacy and the security of patient health information. Which is, that's a lot on that slide. I'll be honest with you. I mean, if that is where we want to be.
Yeah.
For meaningful use. I mean, it's all safety and patient driven at this point.
Now, there are people who would say that electronic or digital storage of medical records is not as safe as paper. But there's also people who would say the opposite.
Right.
I mean, we shouldn't be faxing and emailing our records around.
Right.
But I remember I was in Hurricane Katrina many years ago, and one of the hospitals, there was a little story that came up. One of the hospitals, there was some damage to the building where they kept the medical records.
Right.
And all the papers flew out into the street. So all the patient's information was all over the street during the storm.
Yeah.
And people were picking it up and saying, oh, look at that.
Well, absolutely. Like, Joe Smith really had this really bad infection.
Right.
That's not great. I mean, there is a hard paper trail. There, you hear about criminals with a paper trail. That's how you catch them.
I'll give you another simple example of that is every day when we're scanning anything to run a point of care test.
Right.
You have a lot of times we have to scan one specific sticker. So where do we stick that sticker? Somewhere on the pump.
Right.
Half the time you come back the next day and somebody's left a sticker there.
Yeah.
That doesn't seem like much, but that really is applicable.
And actually, it
And-
has
and
a
patient
lot
security.
of patient health information and demographics
Tied
on
to that, yeah.
Tied to it.
Yeah.
I mean,
And
it's
that- I mean,
anybody with a barcode reader can
Yes.
can really do some damage. So I mean, we're talking about like what do they call it? Identity theft.
Yeah.
So that's
Not that we would do that.
not
as
that
a
we
group,
would do it
but
because
someone could.
Yeah.
Theoretically, if they could gain
Theoretically.
access.
I want to mention one other thing on this slide right here before we go forward. It was interesting because just yesterday, I think it was, today is Tuesday, yesterday I was in a hospital lounge walking somewhere and I happened to look up at the TV screen there and Fox News was doing something on the Trump administration's push for digitalization of medical records, like a new push. And their purpose for that is to make it more accessible to patients. And I was hoping we could get that clip up here to watch and talk about, but we were unable to do that.
I actually have just a little slide what his initiative is.
Oh, good.
But, yeah. I mean, it doesn't explain. It explains a little bit of what he's trying to accomplish. Because President Trump was always trying to take down the Affordable Health Care Act. I mean, I think
I know.
he has
right?
he has a
so this is
vendetta.
one little part
but
that
yes,
actually he agrees
there's
with.
one little part, but he does agree with the electronic medical records. But this along with this EHR and this mandate, there was an actual financial incentive to go to the EHR. It is it was going to be a lot more comprehensive. It was comprehensive for the medical history, and with that, if you read up here, it's talking about the medical history of the patient. So the idea was, if I got care in Louisiana and I moved to Texas, I can easily get my history from that hospital in Louisiana where I got care. So it was a more comprehensive idea in bringing everything all together and having that language speak to come together. So that was quite interesting. You can't really do that with patient charts. I mean, how do you go out to, say, a hospital in Louisiana where you don't live anymore? You're not going to drive 3 hours just to get a paper chart. I mean, yes, it's legally yours, but if I can get something, encrypted, or not even encrypted, if I have a large database that says like, hey, Rodell has this, but now he's getting treated for this, and I can tailor my care for them because of this past history.
Right.
Mm-hmm.
So that was the idea. So that was where the incentive came in. So it was a nice incentive, but along with the incentive, there was penalties. It wasn't much of a penalty, but a penalty nonetheless, because you hit them where it really hurts is the pocketbooks
Right.
of the hospital. It's the reimbursements in Medicare. I mean, I don't know what 1% is, statistically, but it could be quite a bit. I mean, depending on how much your hospital or hospital takes in Medicare reimbursement.
Or practice for a doctor.
Or a practice for a physician, yeah, a private practice, and that's what it also talks about. So incentives and penalties for not employing the EHR, EMR type of technology.
So did we miss the boat as perfusionists and
Did we
lose a bunch of money for the hospitals?
I don't know. I don't quite know about that. But, today, like 96% of the hospitals across the country have adopted EHR. Not just because of this, but, they saw different aspects of why EHR is great. And I'll explain to you, explain later in this presentation, like maybe why it's great. And in 2009, before the Affordable Health Care Act had been passed, only 12% of the hospitals had adopted EHR. Well, that's only 12%.
Oh, wow.
In 2009.
Yeah.
Like, that was well before 2014, but, that's a small number. I mean, that's a big jump.
Yeah.
Right.
12% to 96. I mean, it might be even 98, actually. I've seen a paper where it says 98, but this one actually I could find. So it was quite interesting. Let's see. So let's talk about President Trump.
Oh, okay.
And you talked about you talked about that little clip. It was on Fox. It could have been on CNN or whatever.
Yeah, I'm not a Fox News watcher. But
okay.
Let's not debate.
So
that
let's not get into politics.
Walking past that.
But yeah. So let's talk about Trump's initiative in this. I think it's the one thing he truly agrees with the Affordable Health Care Act. Because he was trying to take it down. And let's be honest, I don't have a view on it. I mean, I'm all about patient care, whether it's affordable health. Doesn't matter.
Right.
So what he did was, what his vision is, basically to obtain the electronic versions of their medical records. Again, that's what I'm talking about, from all providers. So having this, again, one large database in order for better care.
Mm-hmm.
From physicians or hospitals or whatever it is. So it was going to be a lot easier for the care electronically. Because like I said, you're not going to drive 3 hours to
Sure.
your hospital in Louisiana when you live in Texas. So again.
I also, in some of my research on this, I found that Apple is working on a product.
Apple is working on a product.
That would be, it's separate from the My Health Data initiative, and it's specifically for that. It's so that people can carry around their medical records with them as a customer of Apple and pass it off to the doctor.
Yeah,
securely.
Securely.
In some way. Yeah, which is a great idea.
That is a
Yeah.
fantastic idea.
So if anybody knows anything about that or works for Apple and they're watching,
Right.
call in.
So what's interesting about that is a bunch of startups. You saw that slide that said 96 to 98% of hospitals use some sort of EHR.
Mm-hmm.
Well, guess what? A bunch of startups happened. It's a big business.
Mm-hmm.
What's going to be better than the other, and it's a good and a bad thing because now you're going to be competing for the best product and the most secure product and the most comprehensive product,
But that's good for the consumer.
that's good for the consumer and
Sure.
patient,
Yeah.
and as a byproduct, better for the clinician.
Right.
Yeah. And do you want the government to have your health record?
Oh, yeah, that's kind of a Big Brother type of thing.
For me.
For me, it is, but you know, it's. I don't know.
Or do you want Apple might be worse?
Yeah. Hey, I'm an Apple guy and you're a
I'm not an
Google
Apple
guy,
guy.
and I get it. don't start with me on
I'm
that.
stuck in the middle.
Yeah. So I'm getting thumbs down from the peanut gallery back there. So goals for EMR. You know, I mean, it's easy for us. Like let's make something easy. Our job is hard enough.
Right.
I mean, look how many different pieces of equipment we have to work with. Cell savers, heart-lung machines, point-of-care testing devices. Do we want the chart to be something that deters us from paying attention to those things? Like, say I have a problem with my cell saver. Well, oh geez, you know, I'm working on that. Don't even know that 20 minutes has gone by.
Yeah.
You know, I'm still watching my reservoir, but I'm losing focus as to, you know, the pressure, you know, things that are going on with my pump. I mean, it could be doing something. I mean, you know, a catastrophic event.
Yeah.
Or I'm missing the surgeon saying, like, give cardioplegia.
Have you ever forgot to chart for half an hour and
Yes.
then gone back and filled
Everybody.
it in later?
Oh, that no.
You know,
No?
Yes, of course.
I don't
We
care.
all have.
Yes.
If you've done more than say 150, 200 cases, you've
Right.
done that.
I mean,
Yeah, of course, yeah, I know.
no one's
It was-
going to.
I'm just saying,
It was not a real question.
No, I know.
Yeah,
I assumed
it's a
you-
rhetorical
If you said
question.
no,
Then
I
I'd be
would
lying.
say
It
you'd
would be
yeah.
a lie. It would be a lie. It's a rhetorical question. I mean, I think everyone has done it, unfortunately, but you know, we'll see.
Have you ever charted the whole case in the future before you even started?
I can honestly say
I
no.
think
on
there's
that.
some
haven't done
legal ramifications there.
Have not
So,
done that one.
our attorneys, please strike that from this record.
Yeah.
So, and we need a complete and unbiased record, you know, and I think that's something that EMR can provide. You know, it's something that we can't fudge. It's almost that black box mentality. You know, I talked about this like earlier this week with you guys. How come we can take care of patients, but when you're on an airline, everything is absolutely recorded. Every flip of the switch, every button, every act that pilot intervenes on is recorded. And that pilot is accountable for every action. Right. You know, he can show, I did this because of this happening. Where do we have that type of accountability? Like, say my pressure is in the 40s. Where do I ever have anybody say I gave 2 cc's of phenylephrine or any type of vasoactive drug? I don't think I've ever seen it on a manual chart.
You've never written that down?
I have not. I can honestly say
I
that.
stopped writing that down, I'll be honest,
Yes.
many years ago.
Yes.
But I used to. And that also is not electronically recorded, though, you have to realize.
But you could add it in on a lot of these systems.
Right.
That's true. If it's a single button, you
Yes.
could do that.
So yeah, we can talk about that. Yeah, we can talk about that later. But see, an unbiased record, again, it's like I can't fudge the numbers because it's already there. So
Okay, now in the ones in the systems that you looked at, and I know this will, I'd love to have someone call in and talk about this because I worked for Soren, now LivaNova, for a while, and while I was not a Connect expert, it was really just kind of in the trial stages at that point.
The infancy.
I did go on a few sales calls, and you know what happened is that the objection, the main objection from the perfusionist was always, maybe not the objection, the question was, can I go back and change the record if the pressure was in the 40s and it was just very temporary, but that's when it happened to capture? And you know, so that's
a good
my
question.
question is, you know, do
Yeah.
most of the systems
So-
enable you to do that? And
Yes.
is that a good thing or a bad thing?
That is a good and bad thing. So, you know, I'm skipping a little forward a little bit. So when you see that pressure of 40 millimeters of mercury get recorded onto your chart, and you know that's on there, well, you see it live, then you force a line charted.
you force the bad numbers in?
You can force a
good
chart, a good line.
Oh, a good line.
After your
Okay.
intervention, and along with your intervention, like you gave you turned up your flow,
Yeah.
or you gave your vasoactive drug.
Right.
So you've covered yourself that way. Never have I shouldn't say never. I mean, I have charted, like pressures in the 40s, but I write down the reasoning for it and my intervention.
Right.
Right.
So with the one button touch, like with a lot of these systems, that's already done. I don't have this, again, handwriting class. So it's just a one-touch deal. So that's kind of nice.
I now remember as we customized the Connect system for
Right.
customers, the one button that most perfusionists wanted was the one that you could press per surgeon's request.
Yes.
That's actually a big
Yes,
deal.
absolutely.
That's a
So
big
then
deal.
when you got that bad line, you're like, well, per
yes.
surgeon's request.
Or
Yeah.
even better, surgeon notified.
Or surgeon notified, yep.
Anesthesiology notified, CRNA notified. See, again, accountability.
Yeah.
So I think it's a great thing. So this is an interesting one. Number 3 is the application of evidence-based practice and tracing of non-compliant practice patterns. That's a fairly new thing. So what I mean with that is you can tailor your practice with different parameters that will say like, hey, you know what, maybe we should transfuse at this. It'll shoot you an alert saying that like this lab was this. According to, say, I don't know, if you watch my blood transfusion talk, according to Ranucci, the Italian physician with transfusion triggers. If we go by him, something will pop up and say like, hey, maybe we should think about transfusion. So that's kind of some of the infancy with some of these programs.
That happens in case, or that happens
in the case, real time.
So
See,
that's
that's
not
nice,
electronic
real time.
charting, that's electronic
tracking of your practice.
Tracking of your practice.
suggestions. I couldn't
It's
think of the word.
suggestion of your practice,
Yeah.
but it also shows you that like, hey, you know what, this is actually a thing that's helping you throughout the case.
Mm-hmm. Right.
It's
right.
making suggestions. I mean, whether you intervene on it or not is two totally different things.
Right.
But it'll also show up in a progress report, or again. So that ties into data harvesting. You can look at an EMR a lot easier than a fat stack of pump charts.
Yep.
Mm-hmm.
If I wanted to look at the mean hematocrit that
All of
patients
these
come
cases.
in, of a patient that comes in, why are we having a lot of transfusions? Okay, so I want to start a study. What is the mean hematocrit starting before bypass? Well, doctor, it is 29. Well, that kind of paints a big picture.
Should
Now,
we
doesn't
tune
it?
them up?
29, like, hey, should we tune them up? What are we doing here? Why? This is the reason why we're having the transfuse. We are already starting behind the 8 ball. And this is just a small example of what the data harvesting can do, but that could take months, like to try to figure out and calculate what the mean
To input that into
into a database.
Yeah.
That's
paper charting. Yeah.
paper charting. I mean, are you yourself going to go through literally 300 charts? We have a surgeon here that does like 100 to 200 hearts, and he wants to know this, and you know what? We got this for you.
Did any of these systems feed into the STS database or contribute?
Actually, that's a
to
good
that?
question. That is an excellent question. I believe that's my next slide.
I didn't know that. I didn't know that in advance.
No, actually, it's not my next slide. I'm sorry. I talk about that afterwards.
Okay.
So that's quite interesting. Yes, there is a component to the STS in some of these things, or even if there's not, it's a lot easier to harvest now, isn't it?
Yes.
Right.
I can
If you needed it, yeah.
retrospectively go back from the comfort of my desk or wherever you have your brains or your database versus like grabbing a box, full of charts. So
It's an easy way to track and improve your practice and the outcomes, but
Yeah.
at the same time.
Absolutely, absolutely, and you know that's one of the reasons I really like EMR. It's just the improvement of perfusion, and it's just it's a little thing. You wouldn't even think about it. So I found this article. You know, it's an old article, which is kind of interesting. It's something that's from 2005, the future of the perfusion record. I mean, they saw it back then, 2005. It's that's 13 years later. So it's the manual versus the automated data collection.
Right.
You know, it's what's not important is what collected it. It's what it resulted in. You know, what they had 17 cases, mostly cabbages, 16 out of the 17, one ASD, and one out of that 17 was an off pump to go to a cabbage. So, and that's something I actually want to come back to. It's like off pumps. So I want to get back to, what is our level of charting during an off pump? That's something
minimal.
I want to discuss. So I mean,
okay, but yeah, well, I'm just going to write that down because I have four questions.
So that's something
already.
that I want to discuss. I mean, I came from a place that did a lot of off pumps. What was expected to be charted? So it's just a bunch of legal stuff.
Yeah.
It's actually a good question.
Yeah.
Very good.
So, again, the manual chart. The manual chart. I mean, it's basically what we learned in school. It's a line every 5 to 10 minutes. I mean, I've gone as far as like 20, depending on the length of the case. It's like if it's a double valve, I mean, I can paint a picture within 20 minutes, plus or minus, along with labs. So, and the regular stuff was recorded, the map, the venous pressure, the line pressure, the venous sat, crit, temperature, all the normal stuff, okay? And again, the labs of every 30 minutes. I mean, I don't know how often you do, but that's what I've been taught, and that's what I've been doing for the last 16 years.
I chart every 15 and
Yeah.
I do a lab every 30 minutes.
So, I mean,
unless something is going terribly wrong.
Right.
Correct it,
I mean,
then draw new. Or if
yeah.
you have a bad, you don't like your gas, you run a
exactly. You do your intervention that way.
And then
So it's it's pretty much what everybody does. I mean, well, most perfusionists. Not everybody. Most. Let's call it most perfusionists.
Patrick had an interesting story about someone you worked with, didn't you?
Yeah.
Who-
Oh, yeah.
So that was quite interesting.
We are
when
going to
talking.
talk about, I think
Okay.
later you're going to show some charts, but this is
Okay.
probably a good time to mention. I know somebody who I will not mention his initials or name,
Yeah.
but I worked with him, and he would sign the pump record and put down what the procedure was, and then that was it.
Yeah.
And I was like, why are you doing that? And he said the reason is that he thought that if he was ever deposed or whatever, he could make up the entire thing. Nothing was keeping him liable because he hadn't written anything down. Okay, so we'd like to have a lawyer on the show, but we didn't get one.
Yes.
That sounds the exact opposite to me, but I do
So,
see a
Dr.
little
Blitz, if you're out there,
Oh, I
Please.
asked him.
I know
asked him
if
to
you're
be
out
on.
there, you're actually one of our favorite guests,
Yep.
and you are an attorney / surgeon. I would like to know the answer to that. But that is actually not unheard of. I have actually
Really?
heard of an institution where they would dictate their chart. So what does that mean? Dictate their chart.
Really?
Yes. So they had, I won't name the institution. All they did was give their nadir temperature on bypass.
Nader?
Yes, the
Nadir.
lowest.
Oh, okay.
Yes. Their nadir temperature, cross clamp time, perfusion time.
And they would dictate that into a phone or
dictate-
something?
Correct. As if they were.
So they had
like
just a
physician.
sheet paper and just wrote that down, and that was it.
And that was it. They would just pump the case, and that was all they were responsible for. And
Why was it that way? Do you know?
I'm not quite sure. I believe it was an institution thing that has been around for a long, long time. It's not in this state, I'll tell you that. So if things have changed since that,
Yeah.
they have actually gone to an electronic medical charting for that reason alone.
Yeah.
It's because it doesn't show anything.
Sure.
You know, it's like I can make up any number.
Yeah.
Honestly, if there's not even a paper record, what legal ramifications do I have? Like, okay, my cross clamp time was 45 minutes. Would the Perfusion do that you know, the other time? So that was quite interesting. So yeah, I wanted to share that little anecdote. So now this is what's not important, but what's important is the intervals during this automated data collection. You know, this was 2005. I mean, they talk about Windows 2000 as the operating system. That's not important. What's important is how often the automated data was actually being collected. So every 20 seconds, you know, that's you would think that's a lot.
It's probably quite a bit faster than that now.
Yeah, I guarantee you it's faster. And the only reason I did this is because, like, you think 20 seconds is fast. It is, and it is, because, you know, we just said we chart every 15 to 20 minutes.
Yeah.
And this archaic machine is doing it every 20 seconds. So, like, all that.
A lot can happen in 20 seconds.
A lot can happen. Exactly. So, yes. So, if you look at the very bottom, the blood gas was the only thing that was in the keystrokes. You know, everything mostly was automated. I mean, even to this day, you know, that hasn't really changed. You know, you still get the heart-lung machine. To this day, the heart-lung machine data is automatically populated, but the labs are not. That's something you still input. So
eventually that will change, though.
Yes, actually, there is HL7, which I'll explain later what HL7 is. There is going to be communication between all different blood gas analyzers.
Right, because
and other machines.
Now you run an iStat, for example. You run an iStat, you turn around, you dock it for a second, and it populates the anesthesia. They see it.
Yes.
So if we already have that level of access to their machine, I'm assuming that if we're using as a perfusionist in the EMR system, that the same would happen for us.
Right.
Sorry.
Exactly. No. Absolutely. So yeah, that's funny because, you know, we don't even have to dock it at a certain hospital.
That's true.
As soon as it comes up wirelessly, and it can come up right on anesthesia.
Yep.
So we don't even have to hand them that slip of paper, technically.
I
but
wish I
they
knew which
still
one
like
that
it.
was, but we'll talk. I wish I knew which one that was. We'll talk about that later.
Oh, actually, yeah.
'Cause I'm printing it in all the hospitals.
It's the one you take care of.
Oh, okay. Thanks. That was a very good hint.
That's the one you take care of. So, okay. So let me move to the results. I mean, I don't need to go as to, you know, how far the perfusionist was collecting data.
Because it was nowhere near as rapid.
Because it was nowhere near as rapid, exactly.
often,
I mean, I think that last slide just showed a second perfusionist in the room because it was such a new technology, helping out and just, you know, watching things happen.
Right.
So, you know, there was a glaring difference. You know, what was obviously the most notable when we were talking about it is the number of data points collected every 20 seconds versus every 15 minutes. So with that average CPB time of 52 minutes, electronic record resulted in 156 data sets during the bypass with the recording at 20-second intervals. That's quite a bit. And as compared to the manually recorded, on the average of 15.5 data sets.
I would have got 3.
So, I mean, that's 10 times more.
Yeah.
I mean, so that's just showing you, it's painting a bigger picture.
Yeah. Much clearer.
And it's much clearer. So, with the intervals, we're not just talking 10 to 15 minutes, at intervals from 2.7 minutes to 6.2 minutes. So that's quite interesting.
And none of us are charting that fast.
And
that I
no
know
one
of.
is charting that fast. I mean,
Or
Because
that's
that's
often.
all you're doing.
because that's
all you have
exactly
time to do.
you're no longer taking care of the patient. This is a handwriting class.
And that was
be
because
honest.
someone else was in there trying to offset, just see what they could do versus what
Right.
the machine.
Exactly. So yeah, it's a man versus machine kind of deal. So yes,
Have you
that's
ever,
actually
either of you ever
good
been
point.
in a case where it's kind of an emergency and two of us go in and someone helps you out and they say, I'll just do the charting, you handle the patient?
You
Is that
say
a
it to me
good
all the
thing
time.
or a bad? I say that all the time.
You say that to me all the time, Patrick.
Oh man.
No, I'm just kidding.
That is not true. But anyway, I'm
Little
curious
bit.
though, is that a helpful thing or not when that happens? Because I think that relates to our conversation on.
Honestly, I think it's a helpful thing.
I do, too.
I
Yeah.
really do, because you're capturing things that I can't pay attention to.
Right.
And even if, as a perfusionist, kind of like you said, the forced charting,
Yeah.
if something's happening and I want to note it and you're charting for me, I can say, Patrick, can you write down what just
Yeah.
happened? I told the surgeon that pressure's 30 and we've given 2 sticks of Neo. What are we going to do to fix it? He said, forget it, I don't care. Can you chart that for me?
Right.
So same kind of thing with the forced charting. If I know we're talking about that, but eventually you'll hit that button and you'll say, I alerted the surgeon.
Yeah, yeah.
Yeah.
So that is.
So it's a huge help.
I shouldn't say it's a cop out, but it's the truth. It's
the
not
truth.
really a cop out. It's like, hey, I'm covering myself.
Yeah, well, you
Like,
have to protect yourself.
I have to protect.
You have to
myself.
protect that license. You don't.
Yeah, you have to protect that patient and
Yeah, that's
yourself.
true. The patient yourself.
The patient first.
Yeah.
But I don't care if the surgeon is like bearing down on me, which
Some of
we've
them
all had that happen. But he doesn't want to hear it. But I click that button. So again, we're talking about the differences. We all got those things on the manual record, like your cross clamp application, your drug administration, and the blood gas. I mean, that was all on there, along with the manual records. But on the electronic record, it also showed low level alarms, bubble alarms, which is actually kind of bad. I don't know if I've ever.
It is kind of bad.
It's bad if you work with a device all the time that false
right.
alarms.
Yeah.
And we do have
Would you
those.
chart
Yes.
a bubble alarm if
Would
you were
you chart a
manual
bubble
charting?
alarm?
No, you don't.
So
You don't, because we have at least one device we work with all the time.
Sure.
That
Yes.
we're using pulsatile flow, and it
and
hates it.
Yeah.
Yes.
So it false alarms.
yes.
Or you have the stickers when you're putting on your level detector that doesn't stick very well. So what
Right.
do? You just keep reaching over there, thumb it back on, because
Yeah.
you don't have time to put another one on and all that. And so in that case, but then again, you just go back into your chart and say, this is what was going on.
Yeah.
Well, I got a bubble alarm. We'll write that down here.
Yeah.
And then we'll find that bubble.
Yeah,
Yeah,
we'll
we'll
find,
get
we,
that
will,
bubble.
we shall find that bubble.
Hopefully it's not in the brain.
Yeah. So again, those additional events weren't documented.
Right.
So it's quite interesting, because sometimes the perfusionist wasn't allowed, or didn't have the time allotted to be writing these parameters
Sure.
as well. I mean, because of other duties. Like I just said, what if my cell saver just went down, but I needed that 2 units of the cell saver that could have helped that patient?
What if your surgeon likes to give cardioplegia to inflate his grafts to see if he's got a leak in the anastomosis? And you're on, off. You don't have time. I mean, honestly, you don't have time to chart the rest of the stuff.
Right.
Just because you're dealing with cardioplegia and charting that one line every 15 minutes.
Absolutely. So again, that's it all seems very like simple. It's like I'm pointing out these differences, but again, they're differences.
Big differences.
So it really shows the improved accuracy of recording of a perfusion record. It's just it shows the inadequacy of like spot. What we're really doing is doing spot.
A freeze frame of
A
that
freeze
one moment.
frame of that one moment of like your mean arterial pressures, your temperature. We're not getting like 50 data points in that one little picture.
You said 52 minutes.
Yeah.
I'm getting, in that I may get charted 4 times, 1 pre-op, 1 post-op.
Right.
So six
Six
data
lines.
points. 6 lines.
6 lines.
6 data sets, I should
6
say.
data sets.
And
right.
they're getting how many in one of those? 152?
156.
And that's an old version.
An
So
old version. I mean, that's why I want to highlight, an old version. Like, look what's out there now. So, how are we doing on time? Are we doing
Anybody
okay?
know what time it is? I don't have a clock back here.
1 hour, exactly.
We're at 1 hour now?
Wow.
Wow, that's quite
Okay.
interesting.
I guess what we should do then is we should take a commercial break if that's all right with
Yeah,
everybody.
absolutely.
And we'll come back in say 7 minutes approximately.
Yeah.
And we'll go ahead. I didn't know so much time had passed
Yeah.
because
Call us.
We're
I have a
actually having fun,
little
aren't we?
presentation
Yeah,
and
I better
we'll try to get
speed
through
up.
it. So
Someone call us.
Yes, please call.
If you use any
Yeah.
one of these systems, we currently don't, and
Yeah.
we would like to have someone who does speak to us.
what we'd like to hear from is people who have used, well, anybody, but I mean, we'd like to hear from people who have used electronic charting well, you're somebody who's used it and does
yeah,
it
I
now,
have used
so
it. Yes.
We'll
I
talk
had
to you
it.
about that, you know,
Yes.
but then also if any system you have used and maybe it was terrible or it was great, you know, that'd be great to hear. So we can talk about that.
Or even if you're on YouTube, the chat would be nice as
Yeah.
well. You can send us
Yeah, I've
questions.
got chats from Joe Basha, but I don't have anybody else chatting with me over here.
Yeah.
I have a problem with responding to your chat, but I can talk about it, you know, when you chat on YouTube, and I can talk about what you wrote. So, all right, great.
All right.
We'll be back
you.
in
Quick break.
7 or 8 minutes.
Hey, Joe,
Yeah.
you got this urgent letter from the ABCP.
Oh, wow. I wonder what this could be. To Joe Basha from the ABCP. Wow, this looks official. Dear Certified Clinical Perfusionist, the American Board of Cardiovascular Perfusion is advising you that you must submit 10 Category 1 CEU by next week or you will lose your certification. Sincerely, Dave Matthews, PhD, Roger Ramirez, PhD, and the executive co-directors. Let me call my immediate supervisor, Stephanie, and ask her if I can go. This is perfect.
Hello?
Yes, Stephanie, hi, this is Joe.
Hi, Joe.
Stephanie, I just got an urgent letter from the ABCP stating that I am 10 CEUs short, and I've been looking at this New Orleans conference, and I'd like to submit my request to go to that because I really need the credits.
Geez, Joe, I'm sorry I'm not going to be able to help you. Administration informed me they're denying all meeting requests. I guess you're going to have to find another way to get your CEUs.
Oh my God.
Hey, there's nothing I can do. You're on your own, Joe. Sorry.
I'm taking this up the chain of command.
Come in.
Dr. McGilvery,
Hey, Joe.
thank you for seeing me. I don't know what I'm gonna do. I do not have enough CEUs to maintain my certification.
Joe, how's that my problem? Our role is to pay you to do perfusion, not to pay you to go take courses. And it was that way in the past, but we just don't have the money to do it anymore. So you're gonna have to figure it out on your own.
Joe, what's up? Dr. Lumsden. I do not have enough CEUs to maintain my certification, and I'm gonna lose my certification.
We can take all the perfusionists away, we can't do any cases. We don't have enough perfusionists. I don't care about these CEUs. It costs too much money. You gotta stay here and do these cases. Figure out some other way you're gonna get education.
Hey, Joe, you received another urgent letter from the ABCP.
Oh, thank you. Dear Certified Clinical Perfusionist, the American Board of Cardiovascular Perfusion regrets to inform you that because you lack enough Category 1 CEU, your certification is suspended. You are no longer a certified clinical perfusionist. Oh no. I really want to go to this meeting.
Hey, Joe, you received a letter from your job, man.
Hey, dude, thank you so much. Dear Joe Basha, the Health and Happiness Hospital regrets to inform you that because you lost your ABCP certification due to a lack of Category 1 CEUs, you are fired. You must report immediately to the operating room and clean out your locker to make room for your replacement who clearly knew more than you about getting CEUs and maintaining their certification.
Hey.
Imagine trying to drive a car looking only through the rearview mirror. Critical decisions would be based on old and possibly inaccurate information. The same can be true of performing cardiopulmonary bypass without continuous inline blood gas monitoring. Terumo's CDI Blood Parameter Monitoring System 500 continuously delivers 11 critical blood parameters throughout the procedure. with other systems. Periodic blood gas measurements provide static information. That is helpful, but limited. Continuous monitoring tells you what you need to know every step of the way, and that reduces risk. Studies show a direct correlation between blood gas management and reduced complication rates. The CDI System 500 has been earning the trust of cardiac hospitals and cardiovascular surgical teams for almost 20 years. It provides continuous monitoring of 11 of the most critical blood gas parameters, utilizing industry-leading technology. During cardiopulmonary bypass surgery, the shunt sensor can be placed in any arterial or venous shunt, or purge line with continuous flow. The shunt sensor uses optical fluorescence technology to measure PO2, PCO2, pH, and potassium in the blood. 4 microsensors and a thermistor well are in direct contact with the blood to accurately and rapidly measure the values. Light-emitting diodes direct light pulses toward the microsensors, which contain fluorescent dyes. The intensity of the fluorescent light from the microsensors will vary depending on the levels of PO2, PCO2, pH, and potassium in the blood. The photodetector measures and converts the light to numerical data, which is then displayed on the monitor. Blood values are always current with virtually no gaps. There is no need to make difficult judgments about when to draw a sample. Gas source or oxygenator failure can be rapidly detected. Continuous monitoring is especially beneficial during procedures on young or old patients, or with smaller perfusion circuits. Peer-reviewed clinical evidence supports the value of continuous blood gas monitoring. Contact your Terumo sales representative for a demonstration, or visit terumo-cvs.com.
Okay, thanks for staying with us during the commercial break. We are in the middle of a presentation about perfusion charting, specifically a little bit more about electronic charting. But what we're going to pick up on right now is looking at the paper charts that some of us use, and Modell's going to continue with this presentation.
So we just saw a paper that was like from 2005.
Right.
Now we're going to do something from 2018. Okay. All right. So I'm not going to say where this is from, but us three know where it's from. We're looking at, again, these data points. We're just reinforcing what we just saw. Look at the not so much discrepancies, but the differences with a cabbage with these two records. If you actually can look at it, the record on the left has very few comments. And that's just striking. And the one on the right actually has those comments that we were talking about, like all the events, like initiating bypass, the cross clamp, the things that were in that 2005 study comparing it. Mm-hmm. So again, you get disparities. You get You
say that, Rodell. This is quick, interesting. Yeah. I mean, it's not a killer thing or anything, but I noticed right away looking at the two that you say that the one on the right has more, but that's kind of redundant because we're already noting when our clamp time and our initiation time and bypass. So I'm just saying, I'm trying to be critical.
No,
it's a little redundant. So for me, that is one more distraction. When you see my chart later, it won't be on there. There will be other things on there.
I didn't say it was your chart.
Right. So on the next page.
For instance, I used to chart, we're rewarming now. But then I realized, that's in the temperatures. So I stopped charting that. I stopped writing rewarming in the comments section. Because it's clear. If you're going to
started doing that now.
You started writing it?
Yeah.
Why?
Well, my reasoning is I've actually spread out a little longer. I used to chart every 7 to 10 minutes. Uh-huh. Now I do it every 15 minutes.
Okay.
And so my reasoning is a lot of times it'll happen in between when I'm charting between. Now, granted, you'll notice, but there are other instances too when we use that information. I might call you and say, "Hey, Patrick," or text you, "Your next case is up. We're rewarming." So it's kind of for me, it works in many ways.
I see. Okay. So the chart reminds you to call me.
Yeah. Or whoever, or,
right.
For whatever
that's
situation.
What it's for, actually.
Yeah.
That's
all
right.
kind of things like that.
Okay.
So, okay, so let's go to the next slide. You know, these two are vastly different. I know, albeit one's a valve versus a cab, but again, vastly different compared to the first two slides. You know, there is no uniformity with this.
Right.
That one on the right doesn't have any uniformity at all.
So, and again, why is, I'm just to play devil's advocate, why is uniformity important?
Why is uniformity important?
Yeah.
Because, you know, then you can run and see who has any disparaging or practice patterns. Like you can say like, hey,
Nate gives a lot of blood.
yes.
Yeah.
Nate gives a lot of blood.
Or Nate lets his pressure, and I'm Nate, in case you don't know that.
Yeah.
Nate lets his pressure drop too low too often.
Right.
He should be treating that faster when the clamp goes on.
Right.
Whether through flow or through phenylephrine or you know, whatever.
Okay, makes sense. I just thought
It just, you know, if
something we
you
could
see
talk about.
something
question.
uniform, it's a lot easier to pick out like
Right.
that source.
It's
of, if
easier
you
to
will.
extrapolate data that
Right.
in the future that you can use to improve
Yes.
the practice as a whole.
So yeah.
Okay.
That's a good
So
question.
again, see, it's like you got 4 different charts within this group, this
Yeah.
perfusion group.
Same chart, actually.
Same chart. Wow.
Yeah.
I picked it for a reason. So, again, very different. Very, very different. Let's see where we're at. So, and then, oops, David, can you get me back? Sorry. All right. So this is an electronic chart. I obtained this. This was a mitral valve. You know, it's all, most of this stuff is redacted, but it's a very complete chart. You know, it's, let's see where we go. Okay, so yeah, let's get on this slide. So it's got all your demographics.
This is one chart on 4 pages?
This is one chart on 8 pages.
Okay.
On 8 pages. I'm not going to say which company this is, but, you know, because I just can't.
Yeah.
So, you know, it's actually, it's very complete. It had everything that we had in our charts and more.
And more.
I'm sure.
And more,
Yeah.
yeah, of course. So you know, it has all of our drugs. And again, this shows us uniformity. Like if I were to go and do a chart review, I know exactly where to go versus say like Patrick's drugs were on this line
Yeah.
versus Nate's was on this line.
Mm-hmm.
So that's where the uniformity comes into play. So, you know, it's a nice, neat chart. There's no discrepancies. There's no chicken scratch, if you will. I mean, I'm a bit, again, I hate being in a handwriting class, but I just have to have it neat. I'm OCD.
You have
that
very
way.
good handwriting, though. I've noticed that on your charts.
Yeah,
it's very good handwriting.
I like to paint that picture.
Yeah, paint that picture.
There is going to be a time where I get called to the carpet, and is that a 5 or is that a 2?
Yeah.
I don't ever want that to happen. So, and that's not going to happen with an electronic chart, unless there's something that's, you know, that got fumbled. But in a true automated system, that's not going to happen. So, yeah. So that's 8 pages. Or excuse me, 6 pages. 6 pages. The 7th and 8th page was actually the perfusion checklist.
Wow.
So I didn't add that. So that's something that's on the back of our records, you know, and you know that might be a separate thing for perfusionists, or you know, I know one of our hospitals it's a separate sheet, and another hospital it's like on the back of our pump records. So either way, it still gets to the patient's chart. So yeah. So now we're gonna talk about safety. You know, like you know, it's something that's obvious. You know, it just the focus shifts from the laborious, you know, documenting, and it is for me because, you know, I just write everything, and just documenting and focus on the perfusion equipment, and as a byproduct, it improves the communication with the field and anesthesia.
Right.
It's like, you know, it's, well, you know, Dr. So-and-so tells you, Patrick, hey, no, you turn up the ISO or something like that, and you didn't hear it because you're fixed away at, you know, working on this pressure. Well, okay.
Right.
So, I mean, that's just obvious.
A line that came to mind too, we go occasionally and work with other facilities. and sometimes we don't get to work with those surgeons all the time, and sometimes they're hard to understand.
Yeah.
And you might be at a point where okay, normally I would chart, but I'm in kind of a bind. Should I chart here? And it doesn't sound like much, but we're going to be coming off soon. Should I take a gas now?
Right.
Right.
With electronic charting, half that's taken care of.
Yeah.
I'll have time to turn around and do that gas, and maybe take another one after the clamp comes off too.
Yeah.
Because we're using this device.
Exactly. And here's a great article. It's like real-time data acquisition. And alerts may reduce the reaction time, improve the perfusionist's performance during cardiopulmonary bypass.
Real-time data acquisition and alerts may reduce the reaction time. Oh, okay, yeah.
It's true though,
Yeah.
right?
That's what I was talking about.
I'm actually,
I didn't know that was in
I mean, basically the article says we're watching the heart-lung machine.
Mm-hmm.
That is our primary goal.
It is safe
And
patient
it's to
safety,
sit-
and
it just highlights it. It's a great article if you guys find it. Data review. We talked about that STS portion of it. I don't know if there are perfusionists out there that do the STS.
We have a call.
Oh, we have a call.
I'm just going to say it's the boss.
It is the boss.
put the hat back on.
Yes. Yes. How do we answer that?
I did. Swipe. Okay.
Oh.
Hello, we have a very special caller.
You do have a special caller, and congratulations, guys, on doing a great program. But I want to know whose idea it was for Patrick to wear a bald head.
It was Nate's idea.
No.
Yeah.
I asked him to get a mustache.
Yeah.
He said no on the mustache.
Yeah,
He said that was too much.
It's a CLM. It's one of those career-limiting moves that Patrick came up with.
That's called, it's Patrick's going to get extra ECMO shifts. Lots of them. Lots of extra ECMO shifts. So look, a couple of things. One, I sent some YouTube chat, but never got a reply, so I didn't know if you guys were getting them. Number one.
Okay.
Number two, my real question is, you may have already addressed it. How do you guys manage, or how do you propose that it gets managed for groups like us? And who's going to pay for it?
Yeah. No, we
That's a
will
very
get.
good question.
We haven't answered that, but that is the next segment. We are going to touch upon it if we have time. But yes, that's an excellent question.
Joe, when you say groups like ours, do you mean because we cover several hospitals?
No,
Yeah.
I mean a private. Let's say it's a private contract group
I see.
like us.
Right.
And we work at Hospital X, and Hospital X has their own heart-lung machine, but they want electronic charting. Well, then more than likely they're going to be the ones buying the electronic charting, and we're going to use it.
Mm-hmm.
But what if we provide the heart-lung machine, and it's a program where we are doing everything, and the hospital wants it? How do we manage that as a cost? Because it's not cheap by any stretch.
Right. Well, I have one idea on that, and that's kind of why earlier in the show, I don't know if you'd been watching the whole thing, but I brought up STS data, and can this information be easily transferred into the STS data management system? Because that's a point where contractors like us can make money. You can, the hospital has to either have somebody entering that data, or they can use us. So that's one way that we could actually pay for something like this.
It's a very good point.
Well, looking at it from that is one way of you can't look at it, at least I don't think, I guess you can, on how to make money. I'm looking at it just to stay cost neutral.
How to pay for it.
Sure,
right.
not to
How to
lose,
pay for it. Yeah.
not to lose money.
How
Correct.
to pay for the
Correct.
system.
Right.
Because somebody has to pay for it. And so, if you're a private group, and there's a ton of private groups, a lot of private groups like us out there, how do we provide this kind of service in a cost-effective way, both for the hospital, the clients, and for ourselves as a group?
Well, Patrick, you had one example. You spoke to someone. You don't have to say the name of the company, but they had a certain fee that they charged.
Right. Well, it all depends on if if the hospital needs the data electronically, and if they do, and if there, as you talked about earlier, a financial incentive for them to have this information on an EMR as opposed to a paper chart. Well, then that's something that we could charge for. But I think your question is a very good one, Joe, and definitely from our perspective and your perspective as a business owner,
I might be
we
able
need
to
pay
answer
for it.
that in the next segment.
But let me bring up one other thing before
Yeah.
I lose the thought here. On YouTube chat, I'm sorry, I've got it here, Joe. I got some of your YouTube chat questions, or they weren't questions, just some comments early on. And I've gotten nothing else since, so I don't know if there's something wrong with it. And when I don't want to technically lose what I have here, so.
No, I just you never responded to me, so I didn't know if you
weren't
got me
signed
or
in.
not.
If
I could've
anybody,
said thanks,
if
thanks,
anybody
Joe,
has a
instead of-
question and they've been YouTube chatting it to me, I apologize. Call. The number's right on the screen. We'd love to talk to you on the
There you
phone,
go.
and that would be helpful.
All right.
So I apologize if I haven't responded to other questions.
That's all right. Well, listen, I'm going to let you guys finish up that last segment. And where I was at, I couldn't really listen, but I had it on as low as I could, and I picked up some points.
Yeah.
And I do think you guys have done, I just want to say, I think you guys have done an exceptionally good job. And
Thanks, Joe.
just finish it up and finish strong, and I appreciate that. There's like 30 people online watching. So I don't know how many on Facebook, but that's on YouTube.
Yeah. All
Fantastic.
right.
So I was very impressed by that. It's obvious for a subject that can be really dry. I can see a lot of people have interest in it.
I think next time we'll all wear bald head caps, and then
maybe we'll triple the
I got the
triple
mustache.
the viewership. Triple the viewership.
No problem.
Thank
no
you, Joe.
problem.
Thanks, Joe. Thanks for
Joe.
calling.
Have a good time.
Yeah.
Good.
Okay, so let me continue on. We got a little bit derailed. So you're talking about STS.
Yes.
It's actually quite interesting in the data harvesting. Actually, I found an article that supports the use of electronic charting. David, would you just click on that little highlighted thing? So in this slide, I actually highlighted, I don't know why it doesn't show up in Keynote, but what this says is like the centers with the most favorable performance in this validation study, because it's a study, they were more likely to use electronic data capture, have a perfusionist as the STS data manager, and have involvement in the STS database manager in the STS databases. And that and it's something that I'm a little biased, and it's from the Michigan Society of Cardiovascular Surgeons. I did have a little bit of help, or excuse me, have a little bit of involvement in this. But what it's saying is the confidence level of the data was much higher than someone with a manual chart. And it was a lot easier to upload to this registry. So again, this is just another great tool and another reason to have EMR.
Let me throw something else in there too. Again, this kind of clicks back to what Patrick
David,
said
you can come back.
about the expense, trying to promote this to hospitals. I worked for a perfusionist before, for a perfusion group, where one of the perfusionists, that's what he did. So it ate into the time for us, but he was hand inputting everything
STS.
STS off of our charts. So we had to go dig as a perfusionist, and I'm sure he did when he did his cases. We had to go dig and find that data and then put it on the chart, and then he had to transport it over into the STS. Well, I don't know. I have no idea the business side of this for him, but I'm assuming that that's a full-time job for at most facilities.
Oh yeah.
So what are we talking? $80,000 a year plus?
Well, at one of the hospitals that we work at, there was a nurse who she worked in this operating room that was empty and wasn't used for other than just for storing equipment. There's a little computer there, and maybe you've been there, and it sounds like you've been there. And I used to ask her, what do you do? She was this nice old lady, and she'd say, I just enter STS data information all day. That's all I do. And I'm like, really? Okay. So that was her full-time job.
So you're thinking, I don't know, $60,000 a year plus benefits?
I don't know.
So if I'm saying is we could find that out, and that would be a potential revenue stream for us to say, hey, we can provide some of this. And I say us as perfusionists, perfusion groups as a whole, we can provide some of that through this type of system that we're discussing. Sorry. So carry on.
No, No, it's a valid part of the conversation. But how often, what's kind of interesting is how an EMR would populate the information and how it gets disseminated to you. That's quite interesting. I mean, I don't know about you guys, but like I'm kind of finding the patient manual charts being a lot less
Empty.
Yes,
They're
you're
just
finding them
flat out
empty.
empty.
I mean that's what it looks like to me. That's what it is. I am having to harvest the data from a computer. What if there was a way for it to come to my EMR?
Scan the barcode with your
Exactly.
device. Have it read and hook up with the
We got another call, so we're
got
going to
another
take
call.
it.
Let's take it.
Hello, caller. Who's that?
Hey, first of all, I just want to tell you, so the chat part is not working. I was trying to send a chat and
Sure.
it doesn't work.
Yeah, I'm sorry about that.
Okay. But then second of all, I just want to tell them that I do operate the STS data.
Oh, I'm sorry, what is your name?
I'm Beth.
Beth, okay, thanks, Beth.
Uh-huh.
Thank you.
Yeah. So I do operate I manage and enter all the information for STS database. And the issue is, depends on who your software vendor is,
Right.
whether they can take anything off of an EMR or not.
Yes.
We used to work with Lumetics, and now we work with Armis, and
Okay.
Armis does not.
Okay.
Yeah.
Thank you.
So everything, all the information has to be hand entered.
Okay.
So it all depends, because not all STS software vendors are the same.
All right.
So
Right.
is there any,
So-
do you know of any perfusion charting systems that do go into STS data
No.
automatically?
At this,
Well,
go ahead.
It doesn't depend on your perfusion charting. It depends on who your software vendor from STS
Right.
is.
Oh, I see. Okay.
Right.
Okay.
Right. And that was going to be the next slide.
Thank you.
Hey,
Thank you, Beth.
Beth,
No, thank you for
if you want to
clarifying
stay
that.
on the
That's
line for
absolutely
just a
great.
minute, that'd be fine. We're going to cover that right now, and maybe you could
Okay.
talk
Hold
through it
on one
with
second.
us.
Our tech guys were saying to make sure you were signed in. I don't know if you were signed into the YouTube
Yeah.
YouTube chat. You
You
were,
mean-
and it still wasn't working.
You mean I go up to it
Thank
and
you.
it just disappears.
The fact
Yeah.
that I have only received a few means, because normally there's a lot more from what I've seen.
Right.
There's something
Yeah.
going on that I don't understand. So again, I apologize. Just call in, and
Okay.
that's
Thank
fine.
you very much.
Thank you, Beth.
Anything else you
Sure,
want to add?
thanks. That's it. Thanks.
All right. Thank you again.
Bye.
Cool.
Okay, sorry. So she was talking about how things communicate. So this HL7 architecture is kind of interesting. So it's basically what it says is just a bunch of flexible, standards and guidelines and methodologies that the healthcare systems can communicate with each other. I mean, this is something that's not new, but not every EMR has it, and it's gonna start coming. This HL7. So basically, in theory, that it's all going to speak the same type of language. The exchange of information is just going to be a lot easier, and it's going to minimize like the tendency for any variables.
Right.
So HL7 is coming. It's going to be the new standard, so everything can talk to each other.
Right.
It's just going to be like a universal language of data.
Okay.
And how it communicates with your heart-lung machine, your
So
point
not
of care
just software,
testing.
but also devices.
Correct, as well.
Okay.
As well. So that is coming. I know it's not out yet, and it's kind of a laborious process, but HL7 is coming.
Okay.
So yeah, thank you, Beth. Yeah, it was funny. I was going to cover that. So, okay, so let's get to the part where not a lot of us know. So we've decided to go with EMR as perfusionists. What's out there and how do I decide? There's not a lot of data. There's not a lot of information out there. I mean, it's again, you have a lot of startups because of this initiative, and everybody is just throwing something against the wall and seeing if it sticks. I get it. I mean, like any startup, like a hedge fund.
Yeah.
And like anything in life, and just we'll see what works.
Yeah.
This is a brand new world if you think about it. Health information technology is just a huge boom right now. And what do you go with? So I kind of went out there and kind of like tried to get a game plan going and maybe getting a team together. It's kind of funny. It's like, you have the perfusionists who really need to be driving the bus on this, because right now you can get away with in Epic scanning your perfusion record and having it as a PDF.
But how long will that last?
And that's exactly what's going on. That's how we so far as perfusionists have
Yes.
gotten by in
Yes.
compliance with the mandate.
Exactly.
Yep.
And how long can that go on? Again, that's a good question, Nate. How long does that go on?
The security applies to that as well, because how are we disposing of that? How long are we supposed to keep the paper charts?
Right.
And I say we as a group,
Yeah.
or you as a group.
Yeah, exactly. How long do we keep that? So that's we should be again driving that bus, and you have to have anesthesia on board. It's like they are the main roadblock. I think I've been at a place where anesthesia didn't want to give up the paper chart. It's like, okay.
They didn't want to give up our paper chart?
No, they didn't want to give up a paper chart, period.
Oh, I see.
I've been at hospitals where that, or anesthesia has their own EMR, and it may not jive with what we got.
Right.
Right.
So you want to find an EMR that that talks with each other. I think all the hospitals we have a anesthesia, CRNA, anesthesiologist working on some sort of computer. Where are we at on this?
Yeah.
I think we're the only ones really in the room that is working with paper.
There's one facility that way, and I can't think of where it is. One of our facilities still has paper records, but everywhere else that I could think of.
Yeah, exactly. So I don't know, but again, we can't be behind the eight
And
ball
we are.
on this.
We are.
We kind of are.
I mean, as a whole, not just.
Yeah.
I'm not saying just us. Perfusion as a whole is
Right.
behind it.
Yeah. And okay, so this is, I think, the most important yet overseen person, because you just don't think about it, is IT, information technology. They are going to tell you what plays with what. I've worked with IT before, and they don't know anything that's happening in the OR. I try to explain something to him or her, and it just goes over their head. And they explain something to me, and it goes over my head.
Right.
And that's interesting, because I remember from when I did work for Soren years ago, and they were just trialing Connect. The people who went out and implemented that at the trial hospitals, the biggest deal was IT, because IT's job is to protect that data. And it is not to let anybody have access to it.
Exactly.
So, what they had to do is they had to provide, in most cases, a separate folder that was not connected to their system, but that the Connect system could load up the information to, and then it would be, and then someone would manually, push the button to flip it over. But they were not going to give access to their system.
Exactly.
Because that's their job, is not to give
Oh,
access
exactly.
to their
That
system.
is like one of their main jobs.
Yeah.
Again, that's why I call them the gatekeepers.
Right.
They tell us what we can and cannot do. As for the health information. And to answer Joe's question, where does the money? Where does the money come?
Let's try to tackle that
mean,
one.
I think the tactic for like a small perfusion group is actually administration. Honestly, it's got to be on them, because they have to be in compliance. And if again this Epic and scanning in doesn't work, well, there's a burden on us. This is something that protects their end of it and our end of it. So I think it really should get an administrator to allocate some money, and I think that's where you have to start. They've got the big building, and we've got this. When we've got this little building, we have this little office. So we're just a little person in this. So if you can get administration to help and buy into what we're talking about, with the safety, the data reporting, it just makes sense if we can provide that type of service. and you can have an administrator buy into it.
Shoot, you could deal with it strictly alone if you could reduce blood usage.
Yeah.
You might be able to pay off the difference in cost. The hospital,
Exactly.
I mean, pay off the distance. Just if you could change your practice in blood usage alone, because that's a lot of money.
Absolutely. And again, with that evidence-based practice.
Right.
Yeah.
If I can just have that one tiny alert, I mean, let's just say, it's, let's pick a round number, $1,000 a case. That's extremely high. It's not that high. I'm just picking a number.
For
What
using
is the-
electronic
yes,
charting?
Electronic charting.
Yeah, it's
Let's
nice.
just, I'm just using a number.
Yep.
What's it cost for massive transfusion when we didn't need to?
Right.
What's a unit of blood? $2 grand, give or take?
Yeah.
Well, I don't. It could be a whole topic for another show, but the actual cost of a unit of blood to a patient is a lot. It's around $2 grand per
Right.
unit, because of the
Yeah.
unexplained fever and the other
Yes.
issues that come up
Yeah,
later,
transfusion
and the
reaction.
increased hospital stay.
Yes.
Right. increase-
Under a DRG, that they're not going to get that money
Yeah.
back. So.
Yeah. Yeah, we're just talking about transfusion reactions.
Just
We're
that,
not-
exactly.
Just that.
And there are so many other things
and
we can
there's
track.
so
and change
many other
practice.
things you can track and make sure that you fall under the parameters of best practice or
Correct.
evidence-based practice.
That's a great way to describe it.
So that's another reason you can, that's something that'll perk the administrator's ears about.
Mm-hmm.
So, what do I look for? That HL7 architecture, that communication. That's it's going to be the standard. It just when it comes out, it's going to be the standard. So, and this is kind of important in your ORs. Like, what kind of connectivity does this system have? Do we have Wi-Fi? Do we have, LAN cable, the RS-232? So that's the kind of stuff that you need to look for. How are we looking with time, gentlemen?
14 minutes.
We
right?
have 14 minutes?
Yeah.
Okay.
Right?
1 hour, 40 minutes.
Oh,
we
okay.
have
Okay.
another
So
20
we
minutes
have
to go.
another
20
20
minutes.
minutes. All
Oh,
right.
good.
Good.
Oh, good.
All right.
So I have a little time to talk about what's out there.
Okay.
Yeah.
Okay. So LivaNova, you just talked about the Connect system. What's out there. That obviously, all of these right now are going to have that real-time heart-lung machine type interface.
Mm-hmm.
This one is specific to the S5, which is kind of nice. So if you have an S5, it's just going to plug and play. I've seen it. I've seen it in its infancy, and it's kind of nice. I spoke to one of the clinical reps, and he got me excited about what is actually going to be on this thing. I can't speak for it now because again it's in a trial, so I can't speak about it. So.
Well, in general terms, though, I was on the call as well.
Yes.
They have a system that will not only chart for you, but will also help direct your perfusion practice.
Yes.
We were talking about
your
earlier.
case management.
Mm-hmm.
And so they have a nice paper out as well that shows that using this system does improve outcomes, and it's pretty exciting. So
Yeah.
these electronic systems they can go beyond charting. They can also help you with what you should be doing during the case.
Mm-hmm.
So
Could be a little scary on a couple fronts. Could make you a super laser perfusionist.
Yeah.
well,
And then
that was
down the
what I
road,
said. Sure,
It could
yeah.
be automated. We could be automated out, but that's a long way away.
Well,
Yeah,
okay. So when I used to work for
That's a long way
Soren,
away.
and
I'll be retired
people would
by then.
say,
Yeah.
what's the S7 gonna look like? Because this is the S5 right now. I'd say, well, we're gonna give the surgeon a remote control. And there would always be a silence. But,
Yeah.
That's not the case, I hope. We'll see what they do next.
See.
So this figure is their workflow. If you actually look at this, it's like taking that data and exporting it to the actual pump. So like, hey, I don't have to look at a chart.
I
I
personally,
never have to look at a chart because
Yeah.
it's going to be on my pump.
yeah,
I never have to walk over there. I never have to ask the nurse.
The patient chart.
Yes.
sorry.
I never have to ask the nurse to log in because
You need to see a lab.
I need to see a lab.
Yeah.
Or an allergy.
This is all in front of me.
That's nice. That would be very nice.
That is like the goal of EMR.
So can I ask
like
you another
have your own
question?
realm.
Is
Yes.
this an idea where it would be a monitor mounted on the pump that we would look at, or
Yes.
would it be? Could it also be work for a tablet? Because I've seen people working in the OR with tablets before,
Yes.
not just us, but in other facilities.
This one happens to be a monitor that's mounted.
Okay.
Right.
There's a couple of companies out there that can use like the tablet, and we'll get to that one.
Yeah.
We'll get to that one. But this just shows like the type of workflow that you're probably you want to go to. It's like, hey, I never have to go to that patient's chart, or that.
That would be great.
Yeah. I mean, I just think it is because like I'm working in my space. I'm not getting in anyone's way. I'm still looking up at the patient. I'm still looking at the data that this patient presents with.
Hey, you walk into the room on a day, you're having a case where you think such and such is going on. You walk in the room, you think it's going to be an op cab. They crash on induction.
Right.
And you have barely even had time to get in the room and look at the chart.
Right.
With this system or a similar system, you bring it up, bam, it's there.
Yeah.
Height, weight, blah, blah, blah. It's already ready for you. Yeah, most cases we'd like to have that information already written down, but there are times when you don't. You transport them back on a balloon, or you bring them back on an Impella. May not have that time.
Yeah.
Sorry.
So no, never say you're sorry.
I always do.
So McKay now has I mean, this is very new. Like, I couldn't find any information on this. I just found this on the internet. McKay actually has that for their getting gay heart-lung machine. So they have their own plug and play with their heart-lung machine.
McKay has a machine?
Yes.
I know, I was going to say that. McKay has a heart-lung machine?
Yes, they do. They do. See, I try to keep up with all the heart-lung machines and all the technology out there. Yeah, I wasn't, and I was just doing a search, and McKay has one. And, what's interesting, I don't know if anybody has this, this new MetaVision Perfusion. Could they use it for ECMO? Because you have your rotoflows. If I'm not mistaken, is that McKay? Your ECMO. A lot of people are using the Cardio Save or the Cardio Help.
The Quadrants?
Cardio Quip.
No, the Cardio Quip. Is that McKay?
The Cardio Quip device, I believe it is.
Yeah.
The little miniature perfusion device. That
the transport thing for the that's McKay. Mm-hmm.
So I wonder if that
if they have charting for that would be awesome.
I wonder if MetaVision works with that. I don't know if anybody is out there and works with it, but again, that opens up something. How often are we charting for ECMO? I mean,
Well,
we do it every hour,
One
right?
of the systems that, every hour. One of the systems that I did some research on, and I don't think we're going to have time to cover it.
Yeah, we don't have time to cover it, but
that their system covers.
Keep moving here.
What's nice about it is it will chart for autotransfusion, cardiopulmonary bypass, ECMO, and any custom procedure that you do, because we do some kind of custom procedures.
Yeah. Absolutely. So Perfusion Pro is out there. This is actually designed by a 40-year veteran of perfusion. It's very easy to use, very intuitive. This is where a tablet can work. Okay. He has said that you can use a Surface, a Microsoft Surface tablet, if cost is an issue. So that was quite interesting.
To
Windows-based. And what's nice about this Perfusion Pro, if you actually want to trial it, you can actually go to their website and download a trial, and actually play with it. Play with it, and it's very intuitive. It's easy. It's got a nice learning curve. So, and you can actually speak to the owner of the company.
Oh yeah, that's cool.
He actually has his phone number based on that. And he's a pleasant gentleman.
A device like that tie into your pump, or is that something you have to input manually?
No. I mean, there's a few things you have to input manually, such as your FiO2.
Okay.
But
it's
a button. It's a button.
A lot of these are system specific,
right?
Are company specific.
Yes.
But if this is his device,
Perfusion Pro is actually it's not specific to a pump.
Okay.
The most expensive part about building a system like this is actually the interfaces with iStat. In fact, iStat won't work with anybody, so there's no access to iStat.
Until HL7 comes through.
Right. But that is the biggest expense. So this fellow you spoke to, he's got some money if he's running a.
No, I mean it's something that has to be done.
Yeah.
I mean, again, it is a money thing, but the interfaces are probably the most.
We have
expensive.
1 minute left.
No, 1 hour 49.
Okay.
Oh, okay.
Can I? You had mentioned off-pump charting.
Yeah.
Can we talk about that for a minute?
Yeah, absolutely.
Because if you've got one of these systems that is hooked up to your pump and you're not going to go on pump, what kind of charting does it do? Or
That's a good question.
How does that work?
Well, I think right away, because remember, it's not just perfusion charting. This is EMR, so we should be grabbing all that data anyways. I would assume, and I don't know this, but I would assume that they would have some punch buttons, some you could set up a menu for OpCabs.
Yes.
So you say, for instance, okay, the suction cup's on, the Apex cup.
Yes.
Now the stabilizer's on. Things like that.
It becomes a manual entry is all.
Right, I would think, but you're also grabbing your data, the data for pressures.
Right. That's all populating.
It's all populating.
Oh yeah, good point. Yeah.
Yeah, it's all populating.
Because theoretically, again, HL7, these should all be tying in together and downloading that data.
Yeah, that's without HL7, the data will populate.
See, I didn't realize that.
It depends on how it's hooked up. I mean, I know I have experience with Viper. That was tied into with a hard wire, along with the anesthesia machine and every monitor in there. So it was always collecting data. You just had to tell it when to start.
When to start.
Yeah. You tell it when to start. Like you hit these buttons, and you tell it to start, and you tell it when you go on bypass. You tell it when the cross clamp goes on.
Because what are we doing for off-pump charting now? Personally,
nothing.
I chart when we come in the room.
Yeah.
I may chart if there's an event.
Right.
A lot of times I'm busy doing something else.
Yeah.
I mean, I'm not just sitting there reading my phone, but I'm doing something.
So the question is, like, what if that event really didn't, involve us? I mean, we didn't have an intervention to have. Like, besides, like, hey, we're gonna have to go on pump because we've crashed.
Right.
Mm-hmm.
I mean, that's probably the only thing. It's like OpCab to CPB cabbage. I mean, that's the only intervention I would write. I mean, I know what I used to write. I don't know if it was right or wrong.
But that comes back with data integrity.
Yeah.
Because then your data is tied in with what the anesthesia record is showing.
Yeah. Speaking of data integrity, that is actually a good point. What if their EMR doesn't match up with your paper chart?
Always a concern.
It's a huge concern,
right? That's why
right?
we say the clamp is on at, and everybody has to agree on the time.
Yeah, everybody has to.
The blood
there
loss
has to be
was,
consensus.
and everybody has to agree on that.
Don't you actually have I'm not trying to skip ahead, but don't you actually have didn't you have a slide that discussed the difference in data points?
We are
Not
looking
data, not
at,
just
right
time
now,
data
guys,
points.
we're looking at about 5 minutes left.
Yeah.
Well, to finish up what we're on.
No, I mean,
I can't read
and
that.
then there's Spectrum Medical.
Chat.
Yeah.
Oh, well, Joe has called in some questions on YouTube chat.
Sure.
Basically, he says, great job to all of us, which is nice.
Yeah.
I don't know if he's telling us to wrap it up or what.
Well, let me talk about Spectrum Medical really quick.
Yeah, well, let's cover what we can. And by the way, if anybody wants to call, please do, because your time is almost out.
Yeah. So Spectrum Medical, honestly, is probably the most complete out of all the records. They have a database, they have a reporting end to it. They have all three facets of it. They have an ICU, an anesthesia EMR, and a perfusion EMR.
Real quick, I didn't mean to interrupt you, but is this device specific? I know they have their own pump. Is this?
Yes. No, it's not specific. That's actually
Perfect.
a good question. It's not proprietary.
Good.
You can buy the pump, and it's going to be attached with the Spectrum Medical monitor. Okay. The Viper monitor. But yeah, this is the one where, if you talk to anybody, this is the one that's most commonly used, and it's, when I talk to people, they really like it. It's intuitive, it's non-invasive. They have some non-invasive pieces to it, but it shows the quality of their perfusion with this device. And like with all these devices, it's going to show you the quality of your perfusion. This is a paintbrush. Mm-hmm. And showing that, like, hey, you know what? Our perfusion group is fantastic.
But we can improve here,
can improve here, or we're doing such a great job. I mean, it's got many facets to it. It's like, if somebody makes a comment, if some surgeon makes a comment, well, Perfusion X is a better perfusionist than Perfusion Y. well, what are your parameters?
Right. How are you defining?
How are we defining that?
Is it just communication?
yeah.
Does he is he
Is
paying
it
attention?
intangibles? Because I can pull up all the data between X and Y, and they actually run very similar. And heck, maybe Y is better than X.
Yeah.
Yeah.
Now we have a tool to show you what we're doing, not just this one sheet of paper.
I think we're at a point where we need to end this. We're out of time. So what I wanted to say just a few things.
Sure.
First off, thank you, Rodell. That was a
Excellent.
really great presentation, and you pulled us through this. So thank you. That was
I'm
great.
actually a very passionate person about this. It's something that's been on the back burner, and I've always wanted to show what Perfusion has, especially with quality, and if we can do it quantitatively versus just by word of mouth.
Right.
Quickly, a very interesting comment came up years ago at a meeting I was at when off pump was really growing, and the question was to a panel of surgeons: would you be comfortable with having one perfusionist cover 2 rooms that are doing off pump? Good question.
Oh,
right?
that is a good question.
So anyway, all right, we'll cover that some other time.
As a perfusionist, I would not be comfortable.
No.
As a perfusionist, no, but the question was to the surgeon, and it would be to the, But anyway, there are states who require 2 perfusionists for 1 case.
That's correct.
So, Nate, thank you for coming
Thank
in.
you.
I know you had a lot of other opportunities this evening. You did, and both these guys made some sacrifices to be here tonight. We all did. So
Thank y'all for calling.
Beth, thank you for
Joe,
calling in. Joe, thank you for calling in and for your comments. The next show is 2 days from now, September 13th, and Joe will be back hosting again. It's on, what is it on? It's on TAVR, and should we be setting up a...
Patrick Joe or Joe
The
Joe?
real Joe.
The real
the
Joe.
real Joe will be
The
back.
real Joe, please stand up.
So he'll be here talking about TAVR. Should we have a pump primed for that or not? And I believe there's some other things he's going to talk about, renal carcinomas and how that relates to perfusion. So,
that'd be a good talk.
thank you everybody for tuning in tonight.
Thank you.
And
Thank you.
We'll see you again soon.
Excellent. Excellent, guys.
Excellent.
Bye in TV land.
Hey, Joe,
Yeah.
you got this urgent letter from the ABCP.
Oh, wow. I wonder what this could be. To Joe Basha from the ABCP. Wow, this looks official. Dear Certified Clinical Perfusionist, the American Board of Cardiovascular Perfusion is advising you that you must submit 10 Category 1 CEU by next week or you will lose your certification. Sincerely, Dave Matthews, PhD, Roger Ramirez, PhD, and the executive co-directors. Let me call my immediate supervisor, Stephanie, and ask her if I can go. This is perfect.
Hello?
Yes, Stephanie, hi, this is Joe.
Hi, Joe.
Stephanie, I just got an urgent letter from the ABCP stating that I am 10 CEUs short, and I've been looking at this New Orleans conference, and I'd like to submit my request to go to that because I really need the credits.
Geez, Joe, I'm sorry I'm not going to be able to help you. Administration informed me they're denying all meeting requests. I guess you're going to have to find another way to get your CEUs.
Oh my God.
Hey, there's nothing I can do. You're on your own, Joe. Sorry.
I'm taking this up the chain of command.
Come in.
Dr. McGilvery,
Hey, Joe.
thank you for seeing me. I don't know what I'm gonna do. I do not have enough CEUs to maintain my certification.
Joe, how's that my problem? Our role is to pay you to do perfusion, not to pay you to go take courses. And it was that way in the past, but we just don't have the money to do it anymore. So you're gonna have to figure it out on your own.
Joe, what's up? Dr. Lumsden. I do not have enough CEUs to maintain my certification, and I'm gonna lose my certification.
If we can take all the perfusions away, we can't do any cases. We don't have enough perfusionists. I don't care about these CEUs. It costs too much money. You gotta stay here and do these cases. Figure out some other way you're gonna get education.
Hey, Joe, you received another urgent letter from the ABCP.
Oh, thank you. Dear Certified Clinical Perfusionist, the American Board of Cardiovascular Perfusion regrets to inform you that because you lack enough Category 1 CEU, your certification is suspended. You are no longer a certified clinical perfusionist. Oh no. I really want to go to this meeting.
Hey, Joe, you received a letter from your job, man.
Hey, dude, thank you so much. Dear Joe Basha, the Health and Happiness Hospital regrets to inform you that because you lost your ABCP certification due to a lack of Category 1 CEUs, you are fired. You must report immediately to the operating room and clean out your locker to make room for your replacement who clearly knew more than you about getting CEUs and maintaining their certification.
Hey.
Imagine trying to drive a car looking only through the rearview mirror. Critical decisions would be based on old and possibly inaccurate information. The same can be true of performing cardiopulmonary bypass without continuous inline blood gas monitoring. Terumo's CDI Blood Parameter Monitoring System 500 continuously delivers 11 critical blood parameters throughout the procedure. With other systems, periodic blood gas measurements provide static information. That is helpful, but limited. Continuous monitoring tells you what you need to know every step of the way, and that reduces risk. Studies show a direct correlation between blood gas management and reduced complication rates. The CDI System 500 has been earning the trust of cardiac hospitals and cardiovascular surgical teams for almost 20 years. It provides continuous monitoring of 11 of the most critical blood gas parameters, utilizing industry-leading technology. During cardiopulmonary bypass surgery, the shunt sensor can be placed in any arterial or venous shunt or purge line with continuous flow. The shunt sensor uses optical fluorescence technology to measure PO2, PCO2, pH, and potassium in the blood. 4 microsensors and a thermistor well are in direct contact with the blood to accurately and rapidly measure the values. Light-emitting diodes direct light pulses toward the microsensors, which contain fluorescent dyes. The intensity of the fluorescent light from the microsensors will vary depending on the levels of PO2, PCO2, pH, and potassium in the blood. The photodetector measures and converts the light to numerical data, which is then displayed on the monitor. Blood values are always current with virtually no gaps. There is no need to make difficult judgments about when to draw a sample. Gas source or oxygenator failure can be rapidly detected. Continuous monitoring is especially beneficial during procedures on young or old patients, or with smaller perfusion circuits. Peer-reviewed clinical evidence supports the value of continuous blood gas monitoring. Contact your Terumo sales representative for a demonstration, or visit terumo-cvs.com.